Thank you for the nice words.
And one more thing, except the presenter and the discussant, all of you please keep your audio as well as video in off mode. Off mode.
1 second. Can you see the slides? Hello?
First is by Dr. Jagdish. Dr. Jagdish.
Yes, sir.
Okay, be ready. Okay, you have to discuss.
Can you see what is shown here?
Yeah, it is visible.
Okay.
Yes, sir. I can.
Can you identify what is this?
This is endoscopic varicose band ligator clip, sir.
What? Can you tell that again?
EVL band.
Yeah.
Endoscopic varicose band ligator clip.
Okay, this is a band. Actually, it's a band ligator. The tip of the band ligator. You don't. I'm not showing the full thing. So this is sorry. Okay, this is made by one company that has got 7 bands. There are different companies which makes bands. So advantage of this company is that this is made by this is a super the speed band super view. This got a white the penultimate or the last but one band has got a white color. So what is the advantage of that?
That is the last band, sir. It will tell us it is the last band left over the ligator.
Exactly. So can we use this band for a latex allergic patient?
Latex allergic patient.
What are the bands made up of?
Usually,
you have seen bands on tablets and all. No, when the representatives give you samples, what are those made up of? What's the most common material with which these bands are made? You call it?
Rubber.
What is rubber? Scientifically known as? Your gloves is made of latex.
Okay, this is made of material called polyisoprene. So this is not latex, so the patient can, any latex allergic patient can also use this. So this is another company by they make the 4, 6, and 10 shooters. This is Wilson Cook company. So when do you decide to ban Varix? When you see a Varix, how do you decide?
Sir, one is it depends upon the size of the varix and is there any associated with the red color sign or impending signs of bleeding, sir?
Okay. What is the size of the varix?
And if size more than now according to ASLD guidelines, there will be size less than 5 millimeter or more than 5 millimeter. If more than 5 millimeter, it will be called as a large varix. If less than 5 millimeter, it will be small. If more than 5 millimeter associated with any red color signs, red whale signs, like then we need to ban. Small varix associated with impending signs of bleeding, like hemocystic spot or any nipple sign, then to ban even small varix also.
Okay.
So larger varices and smaller varices with the
red color sign.
Hemocystic bands. Okay. RCS. Okay. For hemocystic spots.
Yes, sir.
Right. So these are you can see that the predictors of hemorrhage, the variceal size, red signs, and the even the child the child status is also an important factor. So you must know when you know about esophageal, you should also know about the gastric varices. So how do you classify varix? I've written it here. What are the chances of bleeding, or which varix has got the higher chance of bleeding in gastric varices?
Sir, GOV2 is more chance of bleeding, sir. Higher chance of bleeding.
Are you sure?
Sir?
Are you sure?
IGV1 or IGV1? IGV1. IGV1.
You have to check it and make it thorough, because some people are fond of this, so they'll ask. So what are the treatment options available?
Sir, for GOV1 and GOV2, we can sorry, GOV1 we can go ahead and do the varicose ligation, sir. GOV2 and
where exactly you like it for GOV1?
GOV1 will lower end of the esophagus, sir. Same like circumferential.
So for GOV1, you will only tackle it in the esophagus. Okay, correct. GOV2?
Yes, GOV2 will GOV2 and IGV1 both will need to be like glue injections. First line of management, glue injection we need to do.
Okay. Suppose the patient comes again and again with failed glue injection. Do you have any other option?
Yes, sir. We have other options, sir. One will be the BRTO. If BRTO also failing, then our BRTO or tips, sir. We can decide. We need to explain the patient's this thing, and then we need to take a call either BRTO or tips.
You know any other endoscopic procedures which can treat this other than that before going for that?
Sir.
Again done by Dr. Roy. Done by referred to Dr. Roy very often. When a viruses are not controlled by glue injection. What else can you do?
There is a coils.
Yes.
How do you place it?
Coils.
How do you place a coil? What technique you use? Will you use a usual endoscope or some other endoscope?
Endoscopic ultrasound.
Yes.
Guided coil.
Right.
Yes, sir.
Okay. Before we move on, how will you grade fundal varices or GOV1 or GOV2 varices? Grading. Are you aware?
No, sir. No.
Like F1, F2, F3, or nodular bulbous, like that. Okay, there's a classification. Just read it. Okay.
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 So, have you seen this this device? What is it? This is also used for managing bleeding.
Yes, sir. Upper GI bleeding. There is only one esophageal balloon.
I'm sure you have seen this.
Name of this device. You said half.
Yes, sir.
Huh?
The second part came. The first part was.
Sir,
so this is.
If you look outside, what is light
Linton.
of the?
Yeah, this is in Linton Nicholas tube. You may not have seen this. So, what is the difference between this tube and this tube? What is this tube?
It's a Blackmore Sengstaken tube.
This is Sengstaken black.
Yeah, what is the difference?
Blackmore tube, sir. It has two balloons.
Yeah.
Sir, it has two balloons. One esophageal and one stomach balloon, along with the aspiration in the stomach only.
Jagdish, I say it is Minnesota balloon. How will you say it is not?
Sir, Minnesota balloons has one more lumen, sir. That even it has esophageal aspiration. So it's a four.
So the balloons will be same, but you will have one more port.
Yes, sir.
Aspirate the upper esophagus. Okay.
Yes, sir.
Okay. Dr. Roy was asking about Linton Nicholas tube.
The basic difference between the two is that this has got an esophageal balloon also. The other one has got only gastric balloon. That
gastric balloon, yes, sir.
Yeah, that is it. Okay. So it's got what you have said is right. It has got a triple lumen, and the third lumen is for aspirating. And this is how it is. I'm not going for that. Okay. So I think the two instruments are over for him, sir.
Jagdish, before we find out, what are the other indications of application of band through endoscope?
Sir, other indications, one will be small neuroendocrine tumor, sir, in duodenum.
Okay, very small lesions, okay.
Is there any bleeding, small areas of bleed, like any polypectomy bleeds?
But that is only if the lesion is very small. Okay, so
very.
suppose you have a diffuse lesion. Any diffuse lesion where it is applied?
Sir, this one before Barrett's esophagus, some dysplasia for submucosal dissection or
But EMR, they don't use the same type of band. It is applied on a different type of device. No, okay, banding is there and cutting is there, but it is a different technique. But in people also apply it in GAVE as well as in portal hypertensive gastropathy, where they put multiple bands at different places. Okay, so that is another indication.
Okay, sir.
Okay, now next is Dr. Vivek from Global. Thank you, Dr. Jagdish.
Thank you.
Thank you, sir.
Dr. Vivek from Global. Are you there, Dr. Vivek?
Yes, sir. Yes, sir.
Okay.
So Vivek, you know that forest classification. What is forest classification?
Yes, sir. So forest 1A is spotting. 1B is just oozing from the ulcer. It is, sir, for bleeding peptic ulcer basically. And forest class 2A is non-bleeding visible vessel. 2B is clot just.
That is okay. When do you decide which patient needs treatment?
Sir, when there is acute upper GI bleed patients presenting, and there is forest class 1A, 1B, and forest class 2A. These are the indications for endoscopic endotherapy for bleeding peptic ulcer.
Okay, forest 2B, what will you do? You do what are the chances of bleeding in forest 2B?
Sir, in forest 2B, if we remove the clot, then there is chances of impending bleeding from the underlying vessel. So it can be managed with IBPPI.
Say that once again. Forest 2B, you are afraid to remove the clot.
Yes, sir.
So
There are
you will not remove the clot.
If a patient is hemodynamically stable, then we can manage him medically. If there is instability, then we can go for removal of clot followed by endotherapy like adrenal injection and gold probe application.
Okay, so what's the current thinking? A single endotherapy or double endotherapy, which is better?
So double endotherapy.
Meaning double, that means two techniques are applied on the same lesion. Or a single, for example, adrenaline injection or a heater probe coagulation or.
So combination therapy as compared to adrenaline with gold probe is better, but and when we compare with gold probe, it is gold probe plus adrenaline is not superior to gold probe alone.
Dr. Roy, please.
Yeah, okay. So the visible vessel, the 2B, the chance of bleeding is 20%. So you can decide on depending on the situation, you can do either to treat or not. It's depending on the patient's this thing. What does this identify this accessory?
Is there gold probe for?
Are you sure?
Yes, sir.
So this is actually heater probe. What is the difference between gold probe and heater probe?
Gold probe is bipolar. So in that there is
no, that is not. It's actually the basically the gold probe has got that injection needle with this. So it is you can actually inject also, but heater probe doesn't have that the needle with that, and it's got varying sizes and it can also be used in endoscopes. So this is how and this is how it is used. You have to in the heater probe, you should come in close contact with the ulcer base. Otherwise, it will, that's to minimize the surrounding injury of the tissue. So that is heater probe. And other modalities, as I've already mentioned, you mentioned that injection is there, adrenaline, saline, alcohol, fibrin, cyanoclid, etc. Then the thermal contact is the EC and heater probe. And what is other non-contact one is the APC and laser. Then the mechanical, hemoclip and banding. Okay. So what is this? Picture looks in photograph it may look very magnified. That is very.
Okay, this is used. This is used for management of bleeding.
Sorry.
It is used in peptic ulcer bleeding. Suppose I say.
This is hemoclip resolution. visualization.
Why do you say it is resolution?
Is already preloaded. The size of Joe and
the picture is very magnified. This is not resolution. This is actually the EC clip from the Olympus company. Actually, the difference between resolution and this clip is this has got it's got an applicator with this. So you have to reload each time, a clip. Whereas in resolution, it's a preloaded one. It comes as a unit, And the main difference between the resolution and the Insta clip, this is from the Cook company. It's got a very wide jaw opening, and also it can close and open. Whereas in Olympus clip, it can only be if you close it, you cannot open it. So only single use. Whereas here you can up to five times, it can be used. It is a preloaded clip. It can be used for 5 times, and the jaw opening is more wider. What is this?
This is an APC catheter, argon plasma coagulation.
Exactly. So here you can see that it's a non-contact method. When compared to the other, what other differences between this and the heater probe?
In APC, there are 3 kind of devices. One can be radial, one can be side, and the third is on the end. And it is basically argon-based electrocoagulation, while heater probe is contact-based coactive coagulation.
Yes, here it is non-contact. That's the basic difference. Here it is non-contact, and the electrons flow through the channels, ionized argon. Okay, so that is the basic difference. So only here you can use only in superficial lesions. You cannot, deep lesions. You cannot. If suppose an angiodysplasia or something, or you have to for gay or something like. What are the indications you use APC?
Sir, for gastric intravascular ectasia, GAVE is one indication. Apart from that, can even use for bleeding peptic ulcer, so it can be used.
Peptic ulcer, it is that is why it may not be very effective. It may not be possible to give very effective coagulation in peptic.
I think it should not be used because it is very often arterial or arteriolar bleeding, and it is usually deeper, and it cannot be managed with APC. APC is for very superficial lesions like GAVE, PHG, angiodysplasia, and maybe some people also may use it for SRU, solitary rectal ulcer. Sometimes they use it in radiation colitis or proctitis. These conditions where the lesions are superficial. Okay. Not used for peptic ulcer bleeding. I think you should not say that. If you say that, you may get a negative mark.
Exactly. Okay. So, who's the next?
Next person. Okay, Vivek, thank you. Next is Cyril. Dr. Cyril from Medical Trust, Kochi.
Okay, Cyril, identify this accessory.
Are you there?
Yes, sir.
Okay.
Can you identify?
Self-expanding metallic stents.
Yeah, the two stents are shown. Where
one is a partially covered self-expanding metallic stent, and another is an uncovered stents.
Where is it used?
As a palliative mechanism for palliative therapy for esophageal lesions, strictures, esophageal strictures, benign strictures.
Benign.
And as well as benign, also in benign, as well as
you will get a negative mark because this is not used for benign. Which stents you use for benign strictures?
Biodegradable.
Biodegradable. Yes. Then any other? So in this metal stents only, which type of metal stent you use for? Suppose you want to use, there's no other way. Then which one you use? Benign.
Fully covered.
Pardon?
Fully covered.
Yes. You have to remove it. No, if you in this sense, it may be very difficult to remove. So you can't use this for benign lesions.
Yes, sir.
Don't say benign. This is all for malignant strictures, which we use for palliation.
Yes.
Okay. There are 2 types of releasing. I don't think this is Dr. Ferguson. You want to talk about this? The distal and proximal release. There are 2 types of stent, but most of us use now distal release only. The advantage is you can actually, the foreshortening. The foreshortening, suppose the distal foreshortening, you can, by proximal release, you can reduce the distal foreshortening. So if you want to keep just above the lesion exactly where it is, you have to decide on that. That's not very important, but you must understand that the two distal and proximal release stents are there. What is this stent? You have already answered it.
It's an uncovered esophageal stent.
Uncovered esophageal stent. What difference? I've shown one uncovered stent.
It's a plastic stent. Biodegradable stent. It's a biodegradable esophageal stent.
Exactly. This is a biodegradable stent. That's it comes in this color, blue color. So where do you use it?
For benign strictures.
Yes. It's used only in benign strictures. Malignant, there's no point in using this. So what is the time frame by which it biodegrades? Any idea? Okay. Read about that. And this is called LR stent BD, biodegradable. What is this stent?
It's already written.
Yeah, it's already written.
So I will ask you, what is refractory esophageal stricture?
Refractory esophageal stricture is a stricture which we are unable to attain a 14 mm dilatation even after 5 sessions of esophageal dilatation at a 2-week interval.
Okay, or then one more part. Or inability to maintain a diameter of 40 millimeter for a period of 4 weeks after the last dilatation. Okay, this is a standard question. If there is esophageal stricture, it will be asked. I have seen it being asked in all examination. If there is an esophageal case, so you should know. Okay. So if you are a refractory stricture, what are the methods to treat? Okay, this is one because it's already given here.
We can try local injection of triamcinolone or mitomycin C.
Or
mitomycin C.
Mitomycin C, how is it given? Injected? It's locally applied through a sclerotherapy needle like that, but not injected, sprayed onto the lesions. Okay, not injected. So, triamcinolone injection and mitomycin local spray. Okay, Dr. Roy, about this polyflex stent.
Yeah. So used for benign strictures. So what are the complications of this stent? This is called polyflex stent. And what are the complications? What is the main problem with this stent?
Migration.
Exactly. It's got a very high migration rate. So it's not very commonly used because of that problem only. Okay.
Yes.
So I think
2 instruments are over.
Yeah.
Okay, thank you, Dr. Cyril. Next we have Dr. Rohan from SIMS, Chennai.
Yes, sir. I'm there.
Are you ready?
Yes, sir. Good evening.
Okay.
Okay. Identify.
Yes. So these are silicon bougie dilators. I would like to be specific. These are savory Gillard dilators. They have a distal narrow tapered tip, and the use would be for dilatation of esophageal strictures, benign esophageal strictures, predominantly corrosive strictures.
What are these? Okay, what is the type of, what is the mechanism of the dilatation?
It is a graded esophageal dilatation.
Which all forces are applied? Radial and longitudinal, because we are applying pressure along the long axis of the esophagus, and as it traverses through the stricture, it will apply radial force also. What is rule of 3?
Rule of 3 is in one sitting, we need to dilate by 3 consecutive sizes. These are if the dilators are available in 3 consecutive sizes. That is, if I start with 5 mm dilatation, I can go by 5, 6, and 7 mm in one session. So,
but there is a caveat here. Suppose you have a stricture which is only 10 millimeter in diameter, and you use a 5 millimeter, you can easily use 5, 6, and 7 and will not produce any desired effect. So it should be the first dilator which produces the resistance. That's the point number 1. From that, 2 more. Okay. Not any number you start with. So you have at endoscopy or with the barium solo, you will have an idea of what is the size of the stricture, and then you can decide and then find out which is the one producing the resistance. The first dilator which produces resistance, and that you mark as the first dilatation, and then second and third. Okay.
Yes.
So I said this is American dilator and not Savary Gillard dilator. Have you heard of American dilators? Well, in
I've heard
US,
of it, sir, but I've
use
not
slightly
seen.
different dilators, which actually the tip is actually not very long like this. It is shorter. Okay, very short. Also, Vinigumar is very fond of this question. American dilator. So it will be like the upper portion of a pen with a cap, no, a small
Yes.
sort of cone, and not a very long like this. Do you require radiology support to do this?
Yes, sir. No, for Savary Gillard dilators, it does not require any fluoroscopic support. It just needs a guide wire placement.
Okay.
And
Okay.
if there is blood on the returning dilator, I would know that the stricture has been dilated.
How do you decide that your guide wire is in proper position?
So initially for placement of the guide wire, I would require fluoroscopy.
Yeah, you require fluoroscopy. I don't think.
And therefore, when you take it back after each dilatation, there's a risk that the guide wire also will come up. Okay, unless you are extremely careful. Even a very experienced person want to cross-check the position of the guide wire that it is in the stomach before you introduce the next Savary Gillard. Okay, so I think periodic fluoroscopy will be required to confirm the position of the guide wire. The tip of the guide wire should be in the stomach.
Yes.
Okay. Anything more, Dr. Roy?
Yeah, then the position and that already you discussed, I think. So, okay, now I'll go to the next. What does identify this balloon?
This appears to be the non-compliant Rigiflex achalasia balloon.
Right.
So that is used for pneumatic balloon dilatation, mainly in achalasia cardia.
Why did you say it is a non-compliant? What do you mean by that? What do you mean by that description?
So here the diameter of the balloon will expand irrespective of the resistance felt at the expansion, because the idea of the purpose of the procedure is to achieve a myotomy or the rupture of the inner circular muscles. So that is why it specifically requires a non-compliant balloon. A compliant balloon is which, when distended and there is resistance, it will not dilate further.
People have actually tried compliant balloons and found that it is of no use, because to disrupt an esophageal, that is achalasia, that is spastic esophageal sphincter, we require minimum 30 centimeter, 30 millimeter, that is the size of the 30 millimeter. Okay. So, and what about the pressure? Does the pressure matter?
Yes, sir. So the pressure, it has a attached handheld manometer device. When it is a self-attached manometer. So with the help of pressure about 20 psi, it can be started with a balloon diameter of 3 centimeter, and in the subsequent sessions, it can be upgraded to 4 centimeter, 3.5 and 4 centimeter, depending upon the response.
How do you know whether the current dilatation has been successful or not?
I would look for waste formation in the fluoroscopy. If there is waste formation, that means there is effacement of the stricture.
Or waste formation or a disappearance of the waste?
Sorry, I meant the resolution of waste. Sir.
Okay, so there is a waste in achalasia which has to disappear during a procedure. Okay, so can you predict failure of achalasia dilatation in certain patients? The achalasia dilatation may fail, and therefore you may not think of dilating them, but straight away send for some other procedure.
Yes, sir. Sir, if there is a type 1 achalasia that is a sigmoid esophagus, then procedures like POEM or Heller's myotomy would be preferable to to the use of pneumatic balloon dilatation. So pneumatic balloon dilatation will be preferable for achalasia type 2 or type 3.
What is the complication of rigiflex balloon dilatation?
One of the complications is perforation, mediastinitis.
How do you diagnose perforation?
If the patient complains of chest discomfort after the procedure,
is it only discomfort? I think almost everybody will have discomfort. Yes. And is it done without sedation or with sedation?
Pneumatic balloon dilatation is done with sedation. Yes.
Ideally, all stricture dilatation, especially esophagus, should be done under sedation because it is painful. In India, we are less careful about such comforts of the patient, and we may not do it. But ideally, it should be under sedation, and they will have still some discomfort. Some discomfort is there because they are rupturing the cardiac sphincter, no? But
yes.
severe pain, which is persisting even for some more time. Usually that pain of achalasia dilatation may last for about 5 or 10 minutes. But if the pain persists and the patient complains of severe pain, you have to be careful. What are the signs to look for clinically when a patient is in your observation room after rigiflex dilatation?
I would like to look for a subcutaneous emphysema or
simple patient in distress, tachycardia, subcutaneous emphysema. Where will you look for that?
In the supraclavicular area.
Okay, supraclavicular that will be the area where. And how will you confirm it? Whether perforation is okay?
By an imaging study, preferably a CT scan of the neck and thorax. If there is free air in the mediastinum, that would confirm a perforation.
We can also do a contrast study of the esophagus also. That will be simpler, and it may show a mild perforation where it has not gone through and through. If there is a through and through perforation, maybe we'll have to call in the help of the surgeon. If it is a minor perforation, we may manage conservatively. Okay. So, Roy, anything else?
So, when do you say that it is a successful dilatation? You said one is the disappearance of waste. What else?
Yes.
What
another thing which I've seen we clinically look for is blood on the retaining balloon. So if there is a blood-stained balloon, then that means the myotomy has been performed. So it has achieved its goal of rupturing the inner circular muscle.
Okay. What is the usual pressure which we use for this balloon? I'm sure that you said it's disappearance of waste, but around what pressures it happens?
So 20 psi units or sorry.
No, it's not.
Yeah.
It is usually it is 6 to 7 issue happens. You give it 20 psi pressure, the balloon, everything will burst out. I think. Dr. Varghese Thomas, you have any comment?
Okay, it actually regarding a rigiflex dilatation. In fact, nothing is standardized. Nothing means the size of the balloon, the frequency of dilatation, whether you have to do it every third day, weekly or 2 weekly. Whether you have to use the same size or a different size, as well as the pressure. Okay. So generally what I would suggest is that follow what is given in Schlesinger rather than given in any journal. Still you can say that I am following Schlesinger because the journal examiner might not have read or he may not have read that particular journal. Okay. So what is given in Schlesinger? The pressure given is actually between 5 to 15 or some people say 5 to 20 PSI, but generally we go around 8 to 10. We don't go more than that because at a higher pressure, the system will burst. Yes. Okay. Luckily, this particular system will burst, and the diameter will not become more than 30 or 35, as per which is there on the dilator. But the system may burst. Okay, is it a single use or a reuse balloon?
This is a single use balloon.
But most places it is reused also. So okay, you must know when you reuse a accessory, you should also know there is actually, as per the available information, it cannot be reused, but it is reused. We all put it in the glutaraldehyde and reuse it. Okay, there are risks of reusing it. One more question: what is time barium swallow?
Yes, sir. So time barium swallow is a procedure for the diagnosis of achalasia. So
are you using time barium swallow for diagnosis or for something else? Because we use ordinary barium
Yes.
solo and then maybe endoscopy
Use for the response to
HRM.
Yes, sir. So time barium swallow done at 1, 2, and 5 minutes. It will not only help in assessment of the initial achalasia, but also response to the therapeutic procedure performed.
Okay,
so it can be done after. Yes.
After therapeutic procedure, it can be done to find out the height of the barium column. Some people also do a 3-dimensional. Some people also do it by other methods as well. Okay.
Yes.
Okay, that is.
So,
the other thing is, what are the other modalities? What is the gold standard in diagnosing achalasia?
High resolution impedance manometry would be the gold standard.
Okay. What are the 3 types? You must be knowing that.
Solid state, water perfused manometry.
You said about HRM types already, you know. Okay. Then, what are the medicines used for? Pharmacotherapy of achalasia cardia and menu used.
Yes, sir. One is endoscopically, we can use botulinum toxin as one of the injection.
That's an injection. Now I asked medicine the patient can use.
So one can use calcium channel blockers, NTG can be used as nitroglycerin can be used as a medical line of management. But the response to medical therapy is poor. Even phosphodiesterase inhibitors can be used as one of the medical lines.
So calcium channel blockers, amyl nitrate, glycerin nitrate, or isosorbate dinitrate, then
phosphodiesterase inhibitors.
Okay. So when do you decide to give medical therapy and not achalasia, not rigiflex or surgery or poem?
When
the disease is very mild, or when the patient is having too much risk for any other procedure, and when you think that the longevity is very little, so you don't want to do a aggressive procedure. And I want Dr. Roy to tell something about poem, unless you are covering about poem subsequently.
I'm not covering. So suppose if the manometry shows a type 3 achalasia, what is the treatment of choice for that patient?
Type 3, the treatment of choice would be Heller's myotomy. Type 2 poem would be the ideal procedure for type 2. So
type 3, what is the difference between all this type 1, 2, and 3? What's the major difference between type 3 and type 2?
So type 2 is when there is pan-esophageal pressurization in more than 20% of the swallows. And type 3 is when there is premature contraction or there is the distal latency is low. So that means that achalasia generally progresses from type 3 to type 2 to type 1. So type 3 is when there is only elevated IRP, or the location, the problem is mainly at the gastroesophageal junction. And type 2 is when there is the body of the esophagus is also involved. And type 3 is when there is complete absence of peristalsis, and there is that is the time when patient may develop sigmoid esophagus as an end stage, and that is when these modalities, the pneumatic balloon dilatation, may not work in that time.
No, in which one requires a long myotomy?
So type 2 will require a longer myotomy. Type 1,
no. I think in Lohan, you are a little bit confused. You have to read it again to be absolutely sure. We don't want to reiterate again because of lack of time. You have to review your understanding about type 1, type 2, type 3, and the type of treatment.
Be very thorough with achalasia, because this is a very common question asked, and you should be very, very thorough in it. So, okay, I think.
Okay, and young males and a previous failed balloon dilatation, the success rates are not that very good. Okay, young males compared to others, balloon dilatation, the success is much less. Okay, so we have to discuss with the patient whether they want to come for repeat dilatation or go for much more definite procedure.
So I would like to assess the Eckhart score post the procedure to see for any resolution of symptoms.
Okay, thank you.
Thank you.
Thank you, sir.
Thank you. We will call the next person. That is Dr. Santosh from Medical Trust.
Yes, sir.
Okay.
Yes, sir. Yes.
Santosh.
Sir. Yes, sir.
Okay. Identify these balloons.
Sir, this is a CRE balloon.
Okay.
So the expansion of CRE.
Controlled controlled radial expansion.
Okay.
Balloon.
I gave a clue. Expansion. Okay.
So where do you use this?
Sir, it can be used for a stricture, sphincterotomy. Sorry, sphincteroplasty. Can be used for short strictures and sphincterotomy and plastic.
It can be used in many places where there is benign strictures like. Okay, so this is the device by which you give. You must be knowing this. I'm not going to that.
Okay, yes. What do you mean by actually controlled radial expansion? What is the principle behind that application?
Sir, this is basically this is compliant balloon where this balloon can be expanded with the pressure. So based on the pressure given, the expansion can be there. So that's the principle of this.
So for achalasia, we have 3 different balloons, but here the same balloon we can have 3 different diameter according to
yes,
the higher pressure. Okay. Predefined diameter. Okay. Yes, and if you distance it further, it will burst. Okay.
Yes,
so that's it. It's a multi-diameter balloon. Okay. What is the proprietary material used in CRE? Any idea?
I'm not sure, sir.
It is actually it is Pebax. That's a patented material of the Boston Scientific. So nobody can use this. So the CRE is only with the Boston Scientific. So it's a multi-diameter balloon. 3 different. It's a proprietary material with Boston Scientific. Okay. Yes. Now identify these tubes.
This is a PEG tube, sir. PEG feeding tube.
Yes. More elaborate. Where it is used? How do you use it? How I do it? Or else you can say that.
Sir, it can be done endoscopically through the scope, and it can be used percutaneous way.
Okay, identify the parts of this tube.
Sir, it contain a feeding part, and it contain a balloon, lower balloon for inflation part, and
Dr. Roy, can you just use a pointer so that the item can be pointed?
I'm trying it very hard, but I'm not getting that.
Okay, just okay. Back to that. Okay, then the lower panel, start from the left. There are multiple things shown. Can you identify each of these?
Sir. So there is a thread, there is a caps, and there is a to prevent the tube movement migration and PEG tube and needle and a knife.
What is the usual indication for PEG?
Sir, indication for PEG is for a feeding tube where a patient is not able to tolerate or prolonged RT tube. Patient is on prolonged range tube, or requirement for enteral who requires enteral feed.
So why can't you put the Riles tube for a long period?
So one, it has a chances, it carries a risk of aspiration. Other, it can by itself it can cause even ulceration stricture if it is kept for a longer time. So PEG feeding and feeding is much more.
That's a wider tube.
Wider tube.
Okay.
So you must know it. If somebody asks the steps, you should be able to tell that because it is not that difficult to. You must be knowing it. Yeah. Okay. Right. Identify the accessory.
Sir, is it a US FN needles?
It's a very simple accessory which you do, in and out. You'll be using it, so not difficult. It's just it's a needle. That must you must know. So it is used in the management of bleeding. What is it?
Sir, USFN.
It's a variceal sclerotherapy needle.
Sclerotherapy needle.
Yeah. So, Dr. Varghese, you can.
Okay. Which one? Have you ever done endoscopic sclerotherapy? Because it is not done during our training. We were doing day in and day out esophageal variceal sclerotherapy, but now it is confined to gastric variceal sclerotherapy. So, when you use cyanoacrylate, what are the precautions to be taken?
Precaution. First, we should before inserting the needle, patient it should be needle should be withdrawn and pushed and pulled out before inserting this one, and injection of saline should be done to so make sure that needle is patent, and tube should be retroflexed, and it should be needles should be inserted so that needle comes out, and after that patient endoscopy has to be done, and it should be retroflexed in the fundal first, and the needle should be out. First saline should be injected, and after that once
you inject saline or distilled water.
Distilled water. No, once the needle is patent.
Is it that you can inject any of the things available? Normal saline or distilled water?
Dextrose or distilled water should be used. So normal saline should not be used.
Okay. Then how much?
It should be injected. Needle should be used and it should be punctured. And once punctured, you can inject up to 2 ml. And after 2 ml of glue, and after injecting glue, you should flush with distilled water or dextrose solution. And after that, it should be withdrawn and seen for if the it has surface are hardened or not. If it is not, it's one more setting can be used.
Maximum how much total?
Maximum 2 ml is what can be used.
Some people say up to 7 ml can be gone. Beyond which, what happens?
One injection, you should not use more than 2 ml. But
2 ml, that is it.
Multiple injections, that's not a problem. But one injection should not.
Suppose you use more. Suppose it's a big varix. You might have seen, F3 nodes are like big grapes. And you want to inject more. So what will you do?
High chances of embolization. Risk of embolization is high.
Embolization where?
Pulmonary thromboembolism.
What is the difference? Thromboemboli? What thrombus?
What
is the difference between usual thromboembolism and the thromboembolism occurring after cyanoacrylate? I won't call it thromboembolism.
Because that one can be normal thrombus can be thrombolized. This one thrombolysis won't be working.
Yeah, this will be almost permanent affair. That means it will be a reversible sort of pulmonary hypertension you will be producing, and you will be producing such a tremendous injury to the patient. Okay. Awesome. Now, when you do the procedure, you have to take care of the patient. You have to take care of yourself and to take care of your assistant also, and then take care of the endoscope also. How do you do all those?
Taking care of first and foremost, we should cover our eyes with and even the technicians or people who are assisting
the patients also. Okay, so you have to take care of the patient, your eyes, and your assistants, technician, nurse, who is assisting you. Okay, so protect the eyes, because if it goes into the eyes, it will produce a corneal. If you try to remove it, corneal scarring, all those things will happen. Yes. Number 2.
And protecting the scope. Immediately after injection or during the injection time, needle should not be withdrawn, as the therapeutic channel might get blocked, or working channel might get blocked, and the scope might get damaged. And it should not be aspirated. It should not aspirate when you are injecting the.
In very many units, the suction tube is actually pulled out during the procedure. So by accident, you won't suck it into the tube. What happens if you suck cyanoacrylate into your endoscope?
That working channel will get damaged, and
then you have to replace it completely. There is no cleaning it. Okay, so no suction applied. Then
and it should not be withdrawn.
You should not aspirate back the syringe. Okay, and after the procedure, very often we withdraw the accessory. But in cyanoacrylate injection, we will withdraw only a part of it. The tip will be still kept just outside, and we will pull the entire apparatus out and then cut the biopsy portion outside and then pull it out. And then we will, some people instill something into their biopsy channel in some units. What is that? Some chemical is instilled into their therapeutic channel in some units. What is that chemical?
Sorry.
Acetone. They use acetone. Acetone is a dissolvent. So many people use it, some people don't use it. Okay. So what are the complications apart from pulmonary embolism? Something else also can happen if you are little
one incomplete. There will be a recurrence. There will be a bleeding.
Okay, I am asking you immediate complication. Immediate
pulmonary thromboembolism will be there, and it will be bleeding can be happening at the site of puncture and incomplete glue injection.
Another problem is that if you keep your needle quite long inside that varix after the injection, as you try to take it out, the cyanoacrylate will have solidified around the needle. Understand? So as you try to pull it out, the cyanoacrylate and the needle will have to come out. So you cannot keep it for a long period after the injection. So after the injection is complete, maybe wait for 5 seconds or so, then remove it first. Otherwise, you may produce a tear. The earlier part, people have produced such complications. Okay. Anything else, Dr. Roy? No. What are the other indications or use of cyanoacrylate in gastroenterology?
Other ectopic viruses can be used.
Okay. And, that is all viruses. Okay. Non-viruses indications.
Ulcer bleed can be used.
Ulcer bleed, no.
I'm not very sure. Other indications.
Well, some people, small, tiny fistulas, etc. People inject it around that and try to seal it off. Okay. But not very widely used. It's just experimental, I would say. What is your opinion, Dr. Roy?
Yeah, this is especially if there is a surgical complication like a leak or something. We have used it in patients where there is a leak, when small leaks, it communicates with the cutaneous communication. You can use it just to stop that, put the cyanoacrylate into it.
Okay, so thank you, Dr. Santosh.
Thank you.
Can we move to Dr. Kushan from Apollo?
Yes, sir. Yes, sir. Good evening, sir.
Good evening. Next slide, please.
Okay, what's the name, you said?
Sir, this is a trapezoid basket, sir. It is used in ERCP for extraction and for mechanical lithotripsy of difficult CBD stones, sir.
Okay. So, what are the other ways by which you remove these CBD stones?
Sir, CBD stones, sir, in ERCP, after a sphincterotomy, we can do a sphincteroplasty for the removal of a difficult CBD stone. We can do a mechanical lithotripsy with a trapezoid basket. If it gets impacted, in that case, we can use a Shohendra lithotripter, sir. And sometimes if we don't have a Shohendra lithotripter, or if a cholangioscope is available, in that case, we can use a cholangioscope with a laser lithotripsy or electrohydraulic lithotripsy, sir. And if that fails with that also, in that case, a simple stent is placed and the patient is referred for surgery, sir.
Referred for surgery. So, do you refer all patients? Nowadays, we don't refer patient with the CBD stone for surgery because we have so many modalities. What are the other modalities we use? You mentioned all these things, but the cholangioscope with laser is one of the very good modalities wherein you can avoid surgery. Most of the stones we can pulverize. Okay, yes, when do you decide that this stone is difficult? Before you embark on a treatment, how do you decide the stone is going to be tough? What are the points?
Yes, sir. So the difficult stones can be classified on 3 categories, sir. The stone factors, then the duct factors, and the patient factors. So the stone factors, sir, if the stone is more than 1.5 centimeter, if there's a if the Mirzi syndrome is there, sir.
No. I'm asking about the CBD stone. How do you say that this stone is difficult?
Yes, sir. Then if the stone is behind the stricture and sir, if there is a periampullary diverticulum, and if there is some altered anatomy.
Okay. What are the stone factors you said? More than 1.2 centimeters, okay. What else?
Sir, then more than 3 stones. Sir,
the X-ray shows a calcified stone. What does that
yes,
mean?
sir. Sir,
stone is
it is a pigment. Sorry, sir, I didn't get the question, sir.
X-ray shows calcification of the stones.
Yes,
so
sir.
Is it going to be difficult or easy?
Sir, it is going to be difficult.
It will be difficult to crumble it. That's it.
Very difficult it will be. Okay. So the idea of putting the stent, what is the idea of putting the stent? You don't refer to the surgery. What else you will do? Will you call back the patient after some time and repeat the procedure? After putting
Yes, sir. So we put the stent mainly to prevent cholangitis, sir, and for adequate biliary drainage.
What else? And will it help to soften the stone after some time? The next procedure, will it be easy?
It might be easy, sir. Next procedure.
So how does it help?
I'm not sure, sir.
Okay. So the putting the stent and the long-term friction makes the stone more softer. So the next procedure, it will be more easier to remove it. So that is the reason put the stent and then call back the patient after 6 weeks or 2 months or like that. So that is one reason. Yes. Okay. So Dr. Varghese?
Yeah. That's fine. Next slide.
Okay. This is the, okay. So identify this endoscopic accessory.
So there is a Sohendra mechanical lithotripter, sir.
Okay. Who is this person?
So this is Dr. Sohendra, sir.
Yeah, Nip Sohendra. Okay. So how do you use it? When do you use it? You don't tell about how do you use it. When do you use it? It's actually a salvage therapy.
So save your face. Kushan has some bandwidth issues. Kushan, are you able to hear us?
Sir,
okay, can you repeat? You are not audible to us due to bandwidth issue. Can you repeat the answer?
Yes, sir. This is used as a salvage therapy in impacted CBD stone, sir. So, if we use a trapezoid basket and it gets stuck inside the CBD stone, in that case, we can use a mechanical Sohendra mechanical lithotripter.
What is the difference between a trapezoid and the other basket? Trapezoid has got a mechanism by itself. If you tighten, it will just make it out of the stone. So you can remove that's not with trapezoid. It's with the other basket. The mechanical lithotripter, if you get stuck, use this. Not with trapezoid.
Dormia basket, sir?
The what we have shown earlier, no? The mechanical lithotrips itself,
yes,
or any basket which gets stuck like that, but not trapezoid. Trapezoid got the advantage that it releases itself. When you apply too much of force, it releases itself. So this is a salvage therapy wherein you can go in and can cut and then remove the whole. Otherwise, you may have to shift the patient to the theater with the scope in its mouth or no. Okay, Dr. Varghese.
Yeah, you have to sacrifice that Dormia basket or whichever basket, and then attach it to this device, and then apply rotary movements, and then apply pressure so that the stone will get crushed.
Yes.
Stone will get crushed, and then the stone also will get out, and you will also get out of the endoscopy theater happily. Otherwise, it has happened to me once, where what happened was that wire also got broke. That due to my pressure, that wire got broke and it was remaining in the stomach, and therefore I could come out of my endoscopy room and refer the patient without much shame, because there was no scope hanging from the mouth of the patient. Okay, so whenever you do advanced therapeutic procedure, be aware that you must be ready to tackle all the complications. All complications are just waiting behind you. So you need to know all about all complication. You have to identify the complication immediately, and you should also manage. And you should have a very understanding surgeon along with you in your unit, in your hospital. Okay, and it is extremely bad to refer a patient with an endoscopy complication to another hospital and asking them to look after, and a lot of confusion will occur. So if you have your own surgeon, in-house surgeon, that will be the best. So whenever you do advanced therapeutic procedure, make sure that you have surgical backup also, without which you should not go on to advanced therapeutic endoscopy.
Not only surgical backup, you should have a very interventional radiology.
Okay, can we go to the next slide?
Okay, identify these accessories.
That is because somebody is using two devices.
Can't hear anything.
Sir, these accessories are used for retrieval of foreign bodies, sir. Sir, we have a roth net, we have a red tooth forceps, we have a snare.
Wait a second. Can everybody has switched off the other?
Yeah, I have managed.
Okay. So the number one, what is it?
Sir, that is a red tooth forceps, sir.
Number one, it is not rat tooth, it's a tripod.
A tripod. Okay.
You see the shape, no? It's not rat tooth. Okay, the second one.
That is a red tooth forceps, sir. Second one.
Okay, the third one is written there, basket. Okay, the fourth one, which is commonly used, it's a rock net. Okay, so all these things are used for removing
foreign bodies, sir.
Foreign bodies. Okay, so identify this.
This is a hood, sir.
Okay. So where is it used?
So this is also used for retrieval of foreign body from the esophagus and stomach, and mainly sharp and pointed foreign bodies. It is preferred, sir.
Yes, exactly. To prevent injury to the esophageal G junction and other areas. Okay.
Okay, thank you, Kushan, for your participation.
Thank you, sir.
Next, I'll call Dr. Joe. Are you there, Dr. Joe?
Yes, sir.
Okay.
Okay. Can you identify this? The picture looks a little difficult because this is.
Can give some clue.
This is also used to remove a foreign body.
Sir, I'm sorry, sir, I can't.
Okay. So this is a foreign body retrieval bag. Okay. So this is to remove the small foreign bodies, so footballers, etc. This is like roth net. You can only use once or twice; it will get damaged. So this can be used for more times. And, so that's it. Okay. So what are the foreign bodies you usually see?
Sir, in case of children, most commonly seen as button battery, can be coins, and these new magnet toys these bead-like toys could be seen. Okay. And in case of psychiatric patients, you can even see this trichobazor, this ball of hair could be seen, sir. And a fishbone in adults, fishbone that can get stuck in the cricopharynx or hello.
Yes, we are listening. Okay, so
sir, fishbone, yes, sir.
So children, anything is possible. Anything they can swallow, they will swallow. Okay, adults, if they have a psychiatric problem, of course we can expect same things. But otherwise,
old people,
and okay. Now, how will you manage a patient come to the casualty emergency room who was accidentally swallowed a pin, open safety pin?
Okay, sir. First of all, we'll ask the patient estimate the time, at least the time, roughly the time when he or she had swallowed the foreign body, because by the time, if it is crossed 4 hours, maybe we can be almost sure that it would have crossed the stomach. Could, because the gastric time is 4 hours. So if it's beyond 4 hours, the chance of endoscopic retrieval is less. But to confirm, we can take a X-ray of the patient and we can see where the foreign body is at present. So if we can, if it's within 4 hours, definitely we can give a chance of doing an endoscopic retrieval of the foreign bodies.
What are the precautions when you remove sharpened?
That is, as sir mentioned prior to this, you can always use a hood, rubber latex hood, during the endoscopy to prevent the injury as it crosses the G junction and the the upper residual sphincter.
Okay. Now, suppose you have a patient who has come 2 days after having a fishbone impacted in the upper part. It is just below the tracheopharyngeal sphincter. Okay.
Okay,
what are the things you should look apart from?
Since it's gone almost 2 days, definitely prior to doing an endoscope, we should always do a perforation and see if the fishbone is like maybe it could have been embedded or it could have passed beyond the lumen and it could have been gone extraluminally. So to confirm where the exact position of the foreign body, is always ideal to get a CT scan. And another thing is you can always make sure there is no perforation, because in a case of perforation, doing an endoscope will do more harm for the patient.
Okay, it won't be usually esophagus, there won't be through and through perforation, but it will be penetration and there could be periesophageal inflammation and sometimes even abscess formation. So that also
in that case, we have to treat with the antibiotics and give conservatively.
So we have to take extra care. Just don't remove the foreign body, but you have to make sure that there is no abscess. If there are something to suggest this sort of thing, you have to give antibiotics and keep the patient under tighter observation.
And maintain the nutrition by either total panel nutrition and
Dr. Roy?
Yeah. Yeah, that's basically the thing. So the important thing, emergency endoscopy, in whichever case you do emergency endoscopy, I think still the sound is not getting, a lot of noises coming.
That is, okay, please try.
Yeah, so no, it's still coming. It's the emergency situation wherein you do endoscopies. The foreign body in the
Joe, do you have 2 devices?
Sir, hello.
Only, do you have 2 devices with you? Any mobile also login?
No, sir. I'm just using one device.
Okay, Nikhil, I found out. Okay, now carry on.
Sir, emergency endoscopy, sir.
Yeah.
When is it done, sir? I didn't get the.
It's foreign body, I would say.
So especially these button batteries, the alkali batteries, if it is definitely an emergency, and even these magnet toys, because these magnet toys, they can attract the 2 lumens together and it can cause more injury. So such cases is an emergency, sir.
Why do you consider button batteries should be removed immediately? Why can't they allow these batteries to go down the gut and then pass next day?
Cause these alkali batteries can cause, it may decompose and cause injury to the mucosa.
Okay, it can produce severe caustic injury.
Yes.
Even the fishbone and chicken bone, all those are like you have to do it as an emergency. Okay. It's the same problem.
An emergency.
And causes abscess, that's another problem.
If the patient has classical signs of odynophagia, definitely that means there is, especially fish after intake of fish, that is an indication for emergency.
Okay. Right. So identify this accessory.
So this is a snare.
Yeah. Snare. Yes.
Used for what purpose?
Hello?
Yeah.
It's a snare for polypectomies.
Okay. So where else it is used?
You have given the answer.
Answer EMR, sir, EMR.
Okay. Then we've already shown the picture, no? Removal of foreign bodies.
Oh, okay.
So, which one you will consider that you have to be careful? Difficult polypectomy. Which are those difficult polypectomy or polypectomy after which you can have complications?
Sir, sessile polyps, sir.
Okay,
with,
sessile polyps.
And laterally spreading.
Why? What is the problem with sessile polyp?
So we might not be able to tackle the vasculatures. I'm not sure. Like even we might not get a good plane for polypectomy.
So how do you make the plane? What is the method to make the plane?
You can inject saline into the submucosal space.
You have to lift it up.
Lift it up from the submucosal
lift it up with the
plane.
injection of saline. Okay. Then that is sessile polyp. Then
large stock, difficult samo.
Okay, big size polyp which is very big.
Than 2 centimeter.
Okay, anything above 2.5 centimeter, it is considered a little difficult. Okay, and then polyp which is situated at a very difficult position, like for example junctions, ectosigmoid or flexures, no? That
yes, sir.
will also be very difficult.
Okay, sir.
So what are the complications you see after polypectomy?
Polypectomy, definitely post-polypectomy bleed, especially if the patients are on like antiplatelets, cardiac patients on antiplatelets. Such patients should always be kept on check post-polypectomy for post-polypectomy bleed.
So what will be the advice? You are seeing the patient, you are diagnosed polyp, and what will be the advice? Actually, the patient came with the lower GA bleed. You diagnosed by colonoscopy, there is a polyp. Okay, there is no active ulceration, and the patient is on dual antiplatelets.
Sir, first of all, we should stratify the patient. We should see whether the patient has undergone a stent placement within 6 months. Within 6 months, definitely the patient should be on dual antiplatelets, because if you look at the risk versus the benefit, we can wait for the polypectomy if it is not, and we can just prolong the polypectomy procedure after 6 months if it is within 6 months of the PTCA. If it is way beyond,
I thought it was 1 year for coronary stent. Correct me if I am wrong. For 1 year, they require dual antiplatelets, and when you stop it, you have to be careful. Risk versus benefit. Okay.
And
if it is a high risk patient, you discuss with the cardiologist and stop.
Yes, always discuss with cardiologist.
And for how many days you stop?
5 days prior to the procedure.
And when do you want to restart?
You can restart the very next day.
This is for clopidogrel, not for aspirin. Aspirin you don't have to wait.
Aspirin you can continue, so we can continue with aspirin. Clopidogrel we have to stop for 5 days. Okay. And regarding the anticoagulation, warfarin also it should be stopped at least 5 days prior. And we can, if it is high risk, you'll always have to bridge with the low molecular weight heparin and stop 12 hours prior to the procedure. And the low molecular weight heparin can be continued the very next evening. And also even these DOACs, the new oral anticoagulants, can also be continued the very next days.
Okay. What is the other complication other than bleeding? Okay, how do you manage the bleed?
The bleed can be managed like repeat relook and endoscopy, and if we can use the modality that we use for normal bleeding, like you can use clips, or you can use heater probe, you can even inject and dual therapy.
Okay, so if it is a colon, it's always better to use some clip and prevent bleeding. Suppose the stock is very big.
So even using endo loop prior to, like, if you feel the stock is big, using an endo loop and then going ahead with a polypectomy will prevent bleed, post-polypectomy bleeds.
Okay. So the clip also can be used before polypectomy. You can apply
yes.
Before or
sir, hello?
Okay. You said about when there's a big polyp, big thick stock, you can use an endo loop. Have we heard of piecemeal polypectomy?
Yes, sir. Like if it's a very large polyp that end block or the complete removal in one snap polypectomy won't be possible. In that case, taking it like part by part.
Yeah, piecemeal. You do it in a piecemeal. You don't have to remove it in one big thing as such. You can do a piecemeal as well. What is post polypectomy syndrome, and how do you differentiate it from perforation?
So I'm sorry, I don't.
Okay. What are the other complications of polypectomy?
The
Colonic polypectomy.
Other than
you said bleeding.
Yes, sir.
What are the next important complication which we are all afraid of?
Perforation.
So how will you manage that?
Perforation, definitely post-procedure the patient develops severe abdominal pain, signs of peritonitis. We should always have a clinical suspicion, and then post-procedure such clinical signs are evident. Definitely an imaging with a rectal contrast will give an idea when there is active perforation, and treat with antibiotics and get a surgical gastropenia.
Okay, is there anything short of calling your? Of course, you have to always keep your surgeon in the loop. But as a gastroenterologist, can you attempt to manage perforation?
Yes, perforations using the Ovasco large clips. Ovasco clips can be used. Like if you find the perforation during the procedure itself, you can tackle the perforation by using a Ovasco clips.
So when do you use Ovasco clip? You don't straight away go in for Ovasco clip.
You can try with hemo clips.
When do you decide?
So the size of the perforation.
Yes, but Ovasco is not. You can actually there are different methods of using. One is the hemo clips by you can close it. Otherwise, you can use endo loop. How do you use that endo loop? You know that.
I'm not sure how we use an endo loop for perforation.
By using clips, you anchor the endo loop, and then in different sites you put clips and then tighten it. That is one way of closing the perforation. Then the Ovasco is suppose the size is bigger and you don't cut then only use. Okay.
Okay.
Okay, I think
Okay. I think yes, done well. Thank you, Dr. Joe. You have some more slides, no, Dr. Roy?
Yeah.
Do you have?
Who's next?
Dr. Snija, are you there?
Yes, sir.
Okay, next.
Okay, this is the same. I think it should have been added to the other one. Okay.
Yeah, and your answer is there.
Okay, so what is this, doctor?
It is an endo loop, sir.
Okay, endo loop. Where all you use this? Already it's been discussed. You can just,
in case of a large polyp with thick stalk, we can use it. And as we discussed just now, we have to close the large defect perforation.
What is cold snaring?
Cold snaring without using electrocautery.
Is it advised? When do you use it?
It is advised for polypectomy, sir.
Okay, is it
for less
when
than
it is
5 minutes?
When it is a very tiny polyp, usually we do a cold biopsy sort of thing and remove it. Okay,
yes,
when it's very small. But routinely we use cold snaring?
Yes, sir. It is
when do you use?
Do cold snaring to avoid delayed post-polypectomy bleeding.
I thought we will not do. No, cold snaring means you don't use cautery so that there is no coagulation happening. Your electro-surgical apparatus is not connected at all. No, you just apply mechanical pressure, and with the pressure, the snare, the loop will tighten and it will produce a cut. There is no, during polypectomy, both cutting and coagulation occurs. That is why it gets cut and then bleeding is stopped because the coagulation current is applied and it will coagulate the blood vessels. Okay. Cold snaring means you don't apply any electrical energy. You just apply the mechanical force with your fingers and it will get cut. Okay. This actually happens by mistake most of all. If there is a lack of coordination between the application of pressure by your assistant and your failure to apply pressure on the foot pedal when it is done by two persons. In very many places, the closing of the snare and application of electrocautery is done by the same endoscopist to avoid this complication. Okay, but it can be done if you have got a good coordination between your assistant and yourself. Okay. In a very small polyp, probably we can attempt the cold snare. Am I right, Dr. Roy?
Yeah. In small polyps, cold snaring is better because you can completely remove that.
Otherwise, there won't be any biopsy specimen left.
Yeah.
Everything will be charged.
So, what are the other ways in which you can remove a polyp other than this routine polypectomy and EMR?
We can do a large polyp. We can use endoscopy submucosal dissection.
Okay. So can you tell something about that?
When it is a cell polyp of more than 2 centimeter, and we suspect some submucosal invasion, less than 1/3 of the submucosa, we can do endoscopy submucosal dissection. That in that we will cut through a submucosal plane, and we will.
So, what is the decision? What do you do during the procedure to take a decision? Whether it has gone beyond the submucosa?
We will inject methylene blue.
Okay. And?
Mark the submucosa.
Okay, that is known as the lifting. So that's a lift sign. If the lifting fails or if it is not a smooth lifting, okay, what are the situations where you can artificially get a negative lift sign?
If previously we have attempted a polypectomy, there can be some fibrosis.
Or even biopsy.
Biopsy.
Okay, so flat polyps, if you go on to biopsy, the lift sign can be false positive, and you may think it is invaded, but it is not really gone beyond the submucosa. Okay, so you inject methylene blue, lift it, and then first ideally you have to mark the lesion.
Yes, sir.
Okay, you have to mark all around the lesion, then inject, lift it, and then start cutting it. Okay, Dr. Roy will tell the list.
Okay, so this is the technique of endoloop placement. I'm not going into that. Before that, the EST, so what are the instruments by which use this dissection?
There is knife.
Yeah, at least you should know some
knife.
Some knives which has been like hook knife or TT knife or TT. So many knives are there. Should be, some knives you should know. Okay. Right. Okay. So the next, what is this accessory?
Is it a Dormier basket?
Yes. So again, it has been discussed, but still you can, where is it used?
It is used for the removal of biliary stones.
Is it only used for biliary purpose?
Foreign body removal.
Urologists also use it. It is not confined to use in gastroenterology, but they have got the basket is same, but probably the length and the handle may be all different. Okay. So it's a Dormier basket by which you remove stones and other foreign bodies. Okay. It can be used for different specialties also.
You can even, the smaller baskets, you can try for pancreatic stone removal also after pregnancy. So not only by biliary stones, you can use it for pancreatic stones. If the PD is dilated, and actually there are smaller size baskets for removal of pancreatic stones.
Okay, Dr. Sneja, we have Dr. Kuruvilla. You have any more slides?
I have 60 more slides. You want more than that, 78.
Okay, Sneja, thank you. I will call Dr. Kuruvilla. We have only few more minutes. Dr. Kuruvilla, are you there?
Sir, I am there, sir.
Okay.
Sir, it's sphincterotomy, used for endoscopic sphincterotomy.
Okay. Discuss about sphincterotomy.
That can be wire-guided sphincterotomy with bowstring type. Usually, for use wire-guided for entering the papilla, we use this wire-guided method for entering the papilla and for bowing as well.
Okay.
It has got injection capability as well, this wire-guided sphincterotomy.
Okay. Right. So what are the complications?
Bleeding.
Hmm.
Bleeding can occur, perforation can occur.
Okay.
Then
before, when you cannulate, you can use this for cannulation. Suppose the cannula, I mean, you're using this and then the wire is repeatedly going into the pancreatic duct. What will happen?
Pancreatitis can occur, sir.
So how can you prevent, at least in some way?
Either pre-procedure, you can give rectal diclofenac or pancreatic stent. If you pass more than to the pancreatic duct more than twice, you can put a pancreatic stent to prevent the pancreatitis. Then attempt the biliary.
Is it diclofenac or indomethacin? Which one you prefer if both are?
Indomethacin.
Okay.
Rectal indomethacin is preferred, sir.
So, okay. Dr. Varghese?
Yeah. So is there a method of, so is it just your sheer luck by which you enter the biliary tree, or is there any method by which you can do selective biliary cannulation?
Ideally, the ERCP scopes should be placed in the middle and it should approach from down. So it should be go upwards.
Okay.
In other words, which position is the biliary opening and which position is the pancreatic opening? Which direction?
12 o'clock will be the 11 to 12 will be the biliary, and towards 2-3 will be the pancreatic openings.
Okay. How will you diagnose perforation? What is the type of perforation in sphincterotomy?
It
is
is
it open perforation? Or
it will be retroperitoneal, sir. So
and how do you diagnose it? What are the symptoms?
Symptoms: mild abdominal pain and tachycardia. Abdominal pain will be less. You have to take contrast CT to diagnose perforations.
Okay. How do you manage?
So perforation usually with the self-expanding metallic stent, you can manage the perforation, sir.
Will a stenting required all cases?
No, sir. Conservative management. Conservative management. Most of the time, it is a conservative management. It will subside. Symptoms will subside as the stent is there. If symptoms are persistent,
not very often. This is a posterior perforation and it's a confined perforation. There is no free communication to the peritoneal cavity. It's a localized problem, and sometimes it may get infected, but you can manage it conservatively. I don't think an open management is required in most of the cases. What do you think, Dr. Roy?
Yes. So before doing an ERCP, can you take some measures to prevent the complications like post-ERCP pancreatitis? How do you manage? I mean, prepare a patient for ERCP. At least
IV fluids should be given to the patients with the dextrose. Pre-anesthetic workup, anesthesia.
Okay.
And injection emeset usually they give, and hydrocortisone. Anesthesia they give.
Hydrocortisone, I don't know whether they're giving. I don't know. Dr. Varghese, I don't
think we will use hydrocortisone. Hydration is okay.
Hydration.
Yeah. Indomethacin is okay.
Then in the checklist, you should ask all these whether the patient is. This is always missed. No, many you sometimes you'll miss that whether the patient is taking a clopidogrel or something. So you have to make sure that the patient is not on any of these anticoagulants or antiplatelet drugs. It's very important. So you have to check all those things. Okay. And then the other thing is whether the patient has got any other cardiac, say any pacemaker or any other thing which is attached to him. All these things should be careful.
Okay, sir.
Okay, I think
the next one.
Okay. What is this accessory?
Sir, so wire guided spindle,
No, it's a half of it is correct, but
when you are struggling in your ERCP theater.
So rescue.
No, sir.
Suppose you are trying to cannulate and repeatedly you are not able to cannulate. What will you do? You can hand it over to another colleague.
Okay, sir.
But you can also use another device.
Okay, sir. Needle knife papillotomy.
Yes, but somebody has already put it in chat box. Please don't do that. Okay. Now, what are the risks of using this?
Needle knife.
Needle knife. When you use a knife, what all can happen? Uncontrolled
Perforation
use
and
can
perforation and bleeding. Perforation and bleeding.
Beyond what you expect, no? That can produce bleeding. Okay. And it may inadvertently, and of course, you want to enter the lower end of the CBD, it may produce a wider cut and may produce again a perforation. But generally, as far as possible, this should not be used. That is the general recommendation, and it should be only sparingly used. That's what I feel. Opinion of Dr. Roy?
No, this can be used. Suppose you fail for at least 3 times, you can't. Then you have to use this as a rescue. But the thing is, you need to be very well versed with using this. So you should have some good experience before embarking on needle knife, because this is one with a lot of complications can happen. So to be very careful.
Awesome.
Okay, I think it is 9:35. It's 1.5 hours since we started, and even good things have to come to an end. Okay, because we can't go on a never-ending session. I think we'll have one more session, which is planned for next week, next Thursday, same time. No?
Yeah.
Is it not, Dr. Roy?
Yeah, no problem.
Your second session will be next week. Okay. And we'll also call the remaining other persons who have not been able to participate today. So with these words, we will conclude today's class. And I thank Dr. Roy for having taken so much pains to do this class. And it's a very nice thing. And I am sure also the residents also would have learned a lot with this class. And next week, we come prepared. Just go through your books and other journals and try to read about these various instruments used, and you come better